Yes, so we are back, hopefully, all of us. And I hope that you enjoyed the social event also, because there was the poster session as well as a possibility to chat and to talk to each other. You can always come back to this application in the evening where we have some small social event. You can have another one and meet in this application. You probably noticed the chatting rooms, private rooms where you can meet and discuss anything. But now it's time to move forward, and we have a session number 4 about causes of death, and we have several interesting papers in this session. The first one is from Agnieszka. I just wanted to ask whether you will share the presentation because you sent it. Okay, so you can share the presentation, and if there is any problem, I can share it for you. But it looks fine.
Okay.
Yeah. It looks fine, and I will make a note after 15 minutes so that you know that you should approach to finish your speech. So now it's yours.
Okay, thank you very much. So this is a joint, a collaborative work of Magdalena Muszyńska-Szpilauer, Marketa Pecholdowa, and Sergi Trias-Limos, and me. And I hate to say, but this is really a work in progress. This is for the first time that we have the results, and we would like to present the results. We focus on alcohol attributable mortality, and I think it is needless to say that alcohol consumption is a really important risk factor for adult mortality in Europe, especially in Europe, because here the prevalence of drinking and of heavy drinking is really high relative to other continents. And of course, there are different methodological approaches to estimate the mortality that can be attributed to alcohol consumption. However, other researchers showed that when we focus only on the underlying causes of death, on the data that refer only to underlying causes of death, we can underestimate the real burden of alcohol, because alcohol contributes also to the development of other diseases in one way or another. So in this research, we would like to focus on multiple causes of death. So we would like to introduce not only underlying causes of death, but all other contributing mentions that are written down in death certificates. And in this way, we would like to help to estimate the real level of mortality due to alcohol. Of course, this kind of analysis depends very much on whether the data on multiple causes of death are available for a country or not. And this is the first time that we will be showing the data on multiple causes of death in Austria and Poland ever, especially not only in alcohol, but at all. These data were not gathered or shown before. And our objective is to investigate the pattern of alcohol attributable mortality. So first of all, the level, the scale, but also the structure by different causes that relate to alcohol consumption, by age and also by sex, in our 4 European countries, that is Czech Republic, Austria, Poland, and Spain. And we also want to check to what extent the results are comparable between the 4 countries. So first of all, how do we define causes of death that are attributable to alcohol? Well, there are no surprises here, I guess. Alcoholic psychosis, chronic alcohol abuse,
Recording in progress.
disorders of nervous system, alcoholic cardiomyopathy, a very important one, alcoholic liver disease, and then two ICD codes that cannot be fully attributable to alcohol consumption, but we want to investigate as well chronic liver disease because a high share of death due to chronic liver disease are also due to alcohol consumption. Then alcohol-induced pancreatitis, one group of one cause of death, which is called excessive blood level of alcohol, which was not certified in our data for Austria, Poland, and Spain. It was certified in Czech Republic, but to a very low extent. And then all external causes of death, poisoning, and exposure to alcohol. Okay. Well, we investigate the adult mortality only, so population age 20 and over. What years of analysis? For Austria, we have 2019. For Czechia, we have 3 years, 2016-18. For Poland, only 2013, and Spain, 2016 to 2019. And in all countries, the number of these contributing mentions was either unlimited or very high. So this enables us to make complex analysis. However, in Czechia, only one alcohol-related mention, contributing mention, was allowed per death certificate. So this a little bit limits our data set. In all countries except Poland, there is automatic coding system which captures to some extent deficiencies or errors made during the certification of causes of death. This is important because as you will see, the quality of Polish data is the lowest here. And in Poland, we have still the manual coding system. And just before I start the analysis, I will just tell you how many mentions, contributing mentions we have in each country. So it depends basically on the age. The older patient is, deceased person is, the higher number, average number of contributing mentions, which increases up even to 3 or even 4 per one death certificate, except for Poland, where there is up to 1 on average contributing mention. Because in Poland, if you have a lot of R codes, so these ill-defined or not precisely defined codes, R codes. Of course, if you include R codes into analysis, then this average increases for Poland up to 2 contributing mentions per death certificate, but it is useless to analyze R codes. For other countries, Austria, Czechia, and Spain, if you introduce R codes, it doesn't change much the average because R codes are really quite rare, relatively rare. What kind of methods? First of all, we calculated standardized death rates due to underlying causes that are attributable to alcohol, and also standardized death rate due to multiply causes. By multiply causes, we understand both underlying and contributing, so either underlying or contributing. And we calculate these rates both for the overall alcohol-related mortality or by the groups of alcohol-related causes that I showed you before, 2 slides before. And based on the standardized death rate, we calculate the ratios between the multiply standardized ratios and standardized rates due to underlying causes. So if these ratios are equal to 1, it means that cause is mostly certified as the underlying cause. If it is more than 1, it means that the given cause of death is certified not only as underlying cause, but also as a contributing one. And again, these ratios are calculated both for the overall alcohol-related mortality and also for given groups of alcohol-related causes. So what I'm going to do now, I will show you the results for first for the standardized death rates due to overall alcohol-related mortality. So in the upper panel, we have men, in the lower panel, we have women, and these are standardized death rates per 100,000 deaths, population, sorry. So if we focus on the underlying causes of death, standardized death rates due to underlying causes, you will see that the mortality is the most elevated in Poland for men, then in Czechia, Austria, Spain. For women, the order is slightly different. First of all, it is Czechia, but it's very close to Poland, and then Austria and Spain. If we look at the multiply causes of death, so this red color, you will see that the mortality is almost double, twice higher than if we consider only the underlying causes of death. So we can see the contribution of alcohol into the mortality. The exception is for Poland, where this data on multiply causes of death add very little information on alcohol-related mortality. First of all, as I mentioned, this is the data which is of lower quality as compared to other countries. But also, I think this is also important that we have for Poland the earliest data going back to 2013. And the availability of this multiply causes of death data improved very recently and improves with technological progress in the way how we gather and validate the data. And it might also be the case that that in Poland the quality is quite low because the data is really going back in the time. If we focus on the ratio between the multiply standardized death rate and the underlying standardized death rate, I can just remind you that when it is close to 1, the cause of death is mostly certified as the underlying cause of death. Whenever it is higher than 1, it means that the cause of death is certified also as the contributing cause of death and not only as the underlying causes of death. And here 2 approaches are possible. Either we consider just the number of deaths due to alcohol, so the number of deaths where alcohol is mentioned in the underlying or contributing cause of death. And you can see that in this case, the most informative data are those for Austria and for the Czech Republic. The other approach is that we include all mentions. Each death can have several mentions relating to the alcohol consumption, but not for Czechia. In Czechia, only 1 mention due to alcohol takes place. So in this case, again, the data for Austria and Spain are the most informative. In Poland, I was cleaning the data, and actually, there are two kinds of death certificates. Either you have no mentions, no contributing mentions at all, so really the bad quality of data, or you have several mentions indicating alcohol at one certificate. So in the average, when you look at the number of deaths, the average number of mentions is rather low. But if you include all mentions possible in the data set, there are some information on multiple causes of death. Now I'd like to show you the age pattern of death rates, both for underlying causes of death attributable to alcohol and multiple causes of death in the lower panel. This concerns only men. And you can see a very interesting age pattern differences between the countries. First of all, you can see that this age pattern is younger for instance, Poland, and older, for instance, for Spain, which peaks only at the age of 75, 79. And two other countries that are a little bit in between Poland and Austria. Of course, this corresponds strictly, first of all, to the types of causes of death, and I will be talking about this shortly after, but also this corresponds to drinking patterns, differentials between the countries, the amount of consumption, the percentage of heavy drinkers, types of beverages that are consumed. But just let's keep in mind this inverse age patterns between Poland, Spain, and two other countries between these patterns. Very similar age pattern is for women. However, for all countries, this age pattern for women is a little bit older. Not much, but a little bit older. Okay. So when I speak of causes of death that are attributable to alcohol, what causes of, or what groups of causes of death are the most important? Here are standardized death rates that you already have seen before. On the left, for the underlying causes of death, on the right for multiply causes of death, but this is divided into specific causes of death. So let's focus first of all on the left panel, underlying causes of death. And you can see that for Austria, Czechia, and Poland, the most important cause of death is alcoholic liver disease. And the second most important is chronic liver disease. This is not the case of Spain. In Spain, almost all deaths are related to chronic liver disease. In Austria and Poland, you can also see the impact of alcoholic psychosis, chronic alcohol abuse. In Czechia and Poland, also poisoning or exposure to alcohol. These poisoning, at least in the case of Poland, are in most of all related to low quality of spirits, even methyl alcohol, because I've seen these detailed descriptions in death certificates.
Sorry, you are on 15 minutes.
Okay, so how much time do I have?
Try to approach the finish in a few minutes, please.
So I finished this and I go back to conclusions, okay? And when we look at multiplied causes of death, you will see the reverse order of causes of death. First of all, chronic liver disease, and then alcoholic liver disease. So these multiplied causes of death, they really add they really show the impact of chronic conditions that are rarely mentioned as underlying causes of death. Whenever the underlying causes of death, they represent more acute conditions like poisoning, alcoholic liver disease, or to some extent rare disease. But multiple causes of death add this information about chronic conditions such as alcoholic psychosis, chronic abuse of alcohol, or chronic liver disease. So just maybe, yeah, that would be the last thing to show, that the ratio of multiplied to underlying causes of death for each causes of death is the highest for psychosis, chronic alcohol abuse, and nervous disorders, which are very rarely certified at all. The mortality due to nervous disorders related to alcohol is very rarely certified at all. So multiplied causes of death add the information on chronic conditions, whereas underlying causes of death just show mostly the acute conditions such as alcoholic liver disease and poisoning. So of course we identified differences between the countries in the age patterns, in the structure of causes of death. Unfortunately, we are not able to decompose or to quantify the effect, whether in what way these differences relate to differences in alcohol consumption or in differences in certification practices. So this is why we are going to do this analysis more in a more detailed way. And what we would like to do next also is to investigate to which underlying causes alcohol-related conditions relate the most, the last sentence. So this would be a non-standard multiplied cause of death analysis. However, any suggestion, because this is really the first time that we present these results, any suggestion will be very welcome. Thank you. And sorry for that I exceeded the time. Back to you.
Okay, may I ask a question?
Sorry, I was talking only to the person. Okay, I was calling you okay, sorry. Agnieszka, thank you very much for your presentation, and Alison, ask a question as the first one. Sorry.
It's okay, give you a chance to move my Zoom meeting back to the computer that has that. Anyway, very nice presentation, Agnieszka, and Maya, that must be an awful lot of work trying to put everything together and harmonize as well. One thing that just sort of, this is very Maya thing, one thing that sort of struck me about the earlier Polish age patterns, I was wondering if that might also be related to the earlier period, and maybe this is a cohort-driven phenomenon, because I was just sort of comparing the Polish curves to the Czech curves, for example, and it seemed to always be 5 years apart or so.
Well, you know, with alcohol, it is always a kind of cohort effect, because alcohol is, there is this dependency syndrome for alcohol. I think, however, that this is very important, the pattern of drinking. especially the beverages that are the most popular. Poland differs a little bit as compared to Czechia, especially with the spirit consumption. Czechia uses less spirit than Poland, and I think that this is the impact of poisoning and the exposure to alcohol the most. However, the cohort effect, it is always there to some extent, and I don't know if I addressed your question.
Yeah. Any other questions, remarks to this alcohol-related presentation? No, I don't see any raised hand. Okay, thank you very much again. Or you want to mention?
No.
No? I would like to ask Barbara, and you're already ready. Thank you. The floor is yours.
Yeah, Didong is going to present this talk.
Right. All right. So my name is Jeroen. I'm the presenter of this presentation on cause-specific mortality and about especially the death of despair. So we're going to add a bit more. It's not just alcohol, but also suicide and drug dependence. So this work is a collaboration with colleagues from SET, with Barbara, who is the one that sort of instigated the idea of looking at deaths of despair. But we're also doing it with Sergi, who's going to be talking in this session. And the same applies, I think, to Iñaki, who's also here. So why this topic? Well, I'll provide a bit of a background on deaths of despair, and then I'll briefly mention the data source and methods used before showing some results. So we're a bit inspired, I guess, by the famous papers by Case and Deaton that looked at the US. So, as you know, after increasing for decades, life expectancy in the US as a whole began to marginally decline around 2014, which was driven in part by what they call this sort of the surge in deaths of despair. These deaths of despair, however, had actually been going on for longer than that. In fact, about the midlife and non-Hispanic whites, mortality had been increasing since the late 1990s, especially due to increases in suicide, drugs, and alcohol poisoning, as well as chronic liver disease and cirrhosis. So, but if you then look into a bit more detail, then you actually what they found was not the overall white population, but mainly it was increasing, especially for those with the least amount of education, which for the US is less than or equal to high school. So this is sort of their one of the well-known graphs that they show, and it's a really, of course, a worrying thought that we should be going towards declining mortality and not doubling in a space of 20 years. So what's behind this? What are these explanations for self-destructive behavior? Well, of course, the low level of education doesn't stand on its own. It's often associated with economic insecurity, living in deprived areas, also with, so we say, marriage and child outcomes, for instance, especially in terms of breakup of marriage, that affects both the children and parents, which declines their mental health. And for adults, that also often means because of these health problems, especially mental health problems, they often rely on painkillers and other types of medicine, which is in the case of the US, of course, is quite readily available for various reasons. But these things do not stand on their own. It's really what they mention also as this case. There's a sort of cumulative disadvantage. So it's besides low education, it's also being not having a job, living in a bad end neighborhood, and then having your marriage break up, etc. So what we like to do is to see whether we could whether perhaps in Spain, we see this similar sort of trend in these deaths of despair over the last several decades. We do that by gender and age, and then for the data that is available by education, we also do this by education, which is just for the sort of for this last 3 year period. How do we get the data from? Well, the data trends in all cause and cause-specific mortality were derived from the National Institute of Statistics. Then we looked at deaths between the ages of 25 and 64. And so we look at all ages, and we look also at single ages, and then we have this 2 groups of ages as well. And then we stratify it by age and education, by gender and education. And the National Statistics Institute uses also a matching algorithm since the last, say, 5 or 6 years, to link registered data to population databases such as censuses, municipal population registers, the Ministry of Education, and the Public Service of State Employment to obtain these deaths also according to educational attainment. They also provide the total population broken down by sex, age, and educational attainment, which are required, of course, for the denominators of our mortality indicators. And based on both data sources, we create 3 educational categories: low, middle, and high. So the causes of death themselves, they're sort of spread across 2 ICD classifications. From 1980 to 1998, ICD-9, and then from 1999 onwards, ICD-10. We standardize mortality rates using also the 2013 European Population Standard Population, and for the educational differences, we also calculated confidence, 95% confidence intervals. In terms of the causes of death, so as I said before, we look at these deaths of despair. Particularly, we have these alcohol-related deaths, then we have drug-related deaths, and then we have suicide. To add up to 100, so we get also the other natural causes and the other external causes. We analyze them besides. These cause of death groupings are an adaptation from the works by Case and Deaton and also an ELEC. And so basically, if we compare them with Case and Deaton, we basically combine chronic liver disease and cirrhosis with alcohol poisoning, as well as alcohol-related disorders to create this pure alcohol-related deaths. And with the in terms of drugs, we use the mental behavioral disorders due to the use of drugs, which excluding tobacco and alcohol, and also accidental poisoning by exposure to drugs, again excluding alcohol, to create this drug-related disease group. And so we to go now to the results. As this first figure here shows, we observed over the last, between 1980 and 2019, a decrease in the all-cause mortality rates for both genders. Overall, male cause mortality rates were much higher, of course, than as expected, than female rates throughout the period, but they declined among both genders. Although among men, it was not until the early 90s that you had this decline. So as a result, mortality rate ratio between men and women actually increased from 2.1 times more male than female deaths in 1980 to 2.6 during much of the 1990s, before declining again to 2.1 in the late 2010s. In terms of the cause of death of despair, the downward trend is particularly visible for alcohol-related mortality, which is in yellow. And the trend is again quite similar for both genders, with higher mortality rates among men in each of the 3 specific causes. As a proportion of the total, the deaths of despair actually hovers around 9.10% in the case of men, and 5 to 6% in the case of women. But it declined between the mid-1980s and late 1990s here, before stabilizing in the case of women, but it actually started to increase again in the case of men. And this can be better perceived in the next figure, where we looked at because deaths of despair are clearly age-related, especially alcohol-related deaths, but also drug-related deaths. So because of the literature health effect of alcohol is usually through prolonged intake, we therefore created this heat map of the age-specific rates. So we see that in the 1980s, alcohol-related mortality was very high among the 50 to 64-year-old men, but rates actually gradually declined over time, as also among the younger ages. However, deaths were rare until the mid-1980s and still among women in terms of the drug-related deaths. Here, there are almost no deaths at all, but suddenly increased among 25 to 39-year-old men as illicit drugs became readily available after Franco died in 1975, and the country opened up its borders and became more prosperous, and which was exacerbated by the fact that by the mid-1980s, in some regions of Spain, up to half of all youths were unemployed. Also, there was also the possession of illegal drugs also was no longer punishable. So you had this really steep increase here, but temporary, because between the late 1990s and 2010, the mortality from illicit drugs drastically declined among young men. Although the middle-aged men now, we see a sort of slightly reverse trend, because you see it sort of increasing the last decade or so. And this is something we'd like to know a little bit why that's the case. In terms of suicide mortality, it's actually been high and stable throughout the whole period. And women as well, but not as at a lower level. So if we now group these 25 to 60-year-olds, 5-year-olds, 64-year-olds in two groups, we see for the younger adults, actually, that you see this, in terms of drugs, you see this really huge increase among men, and then a big decline again, and stabilizing. And for the alcohol-related diseases, actually was a very steep decline, actually, starting from the 1980s. While again, the suicide rates actually increased during the 1990s, and is now stable again after a slight decline during the 2000s. In the case of the proportion, is among of those three causes of death in relation to overall total mortality is a concern, because as you can see that overall mortality, of course, has also declined quite a lot, and as a proportion, these three actually have increased now from about 12% to more than 20%. In the case of women, the trends are less steep, shall we say, but again, suicide is very stable over time, and overall, you do see that as a proportion also, there's a slight increase that these three causes, that people are dying from these three causes. If we look now at the higher ages, we see that there's a scale difference we have to remember here as well. There's, of course, more people at these ages are dying than at the younger ages, but you see again this huge decline in alcohol, which is then translated into the overall of the three. But again, it's a slight increase going as a proportion of these three causes of death as a proportion of the total. And you see also among the drug-related, although it seems very little, virtually zero in the 1980s, there is a noticeable increase in the last decade. So yeah. So if we now look at for the last 3 years, between 2017 and 2019, we wanted to see how if these deaths of despair are different according to educational attainment. And the general pattern is that you have higher rates of mortality among the low educated, especially which is found for the specific causes of death of despair that were analyzed, so alcohol, suicide, and drugs, with of course with high levels in men and then in women, as we would expect, but where also the educational differences among women are actually less pronounced than in the case of men. You can see here among men the highest educational differences are found for alcohol and suicide. In the case of the former, 2.1 low educated men died per population of 10,000 during the study period, compared to just 0.5 of high educated men. Among women, a marked pattern in mortality is only observed for alcohol related more diseases where low mortality, low educated women have the highest levels of mortality of about 0.5 per 10,000. So the low educated women die just as frequently as high educated men, interestingly enough. So, but the with respect to the other two categories, suicide and drug-related diseases, in the case of women, there's actually no real educational differences. So if we now go to the conclusions, we can say that in Spain, we do not see the same pattern than in the US in terms of overall this huge steep increase in decline in mortality from the deaths of despair. In fact, it's the overall pattern is a decline, although as a proportion of the total mortality, there are some increases have been observed in recent years. So a possible explanation, well, maybe a more generous safety net in Spain. So especially family becomes, I think, it's an important factor. I mean, youth or young adults tend to still be living with their parents until the late 20s, and so unlikely, and rather than leaving home at 18, so you're unlikely going to be a drug addict. It's less likely to sort of fall into these shall we say, patterns of behavior which are bad for health. But also perhaps the state might play a role too, in terms of unemployment benefits, or just also, of course, the whole healthcare system as well probably is here more protective for health than in the US. But still, that said, there's a little lack of improvement in suicide is, I think, a concern that we should look at trying to improve. So overall, mortality rates are substantially higher in men than in women, with also little change over time in that respect. And there are educational inequalities in deaths of despair, and we're able to just only analyze it for the last few years, but still, the levels among low-educated men are worrisome. Among women, suicide and alcohol deaths among low-educated are also relatively high. So the reduction of premature deaths, in this case, we looked at in alcohol, suicide, and drugs among low-educated, especially young adults, should clearly, of course, be an important public health policy. If we, looking ahead of what we would like to do is, of course, once the data become available, is to sort of see whether the COVID pandemic can be considered also, could be considered a major stressful event that could affect this mental health and well-being of the population. So it would be interesting to see whether during the last couple of years, what the trend of these three causes have been, and maybe there are other deaths of despair also that could have been a consequence of the pandemic. It might be, for instance, in the case of hard drugs, they might have been less available, so we might see a continuation of the downward trend. Alcohol is, well, the supermarkets here have been open pretty much the whole time, so maybe, but on the other hand, people weren't able to go and go out to the bars and nightclubs and stuff to drink. So, but on the other hand, they were able to drink at home. So it's going to be interesting to see how that's going to have repercussions for alcohol-related and drug-related diseases, of course, as well as suicide. So I would like to acknowledge, of course, our funders. It forms part of Inyaki's ERC grant that most of you are well aware of. Also, I recently obtained this, just this month, I've started a project on the gender and socioeconomic inequalities of comorbidity and multiple causes of death. So I'll definitely be writing to one or several of you over the next maybe few months, maybe to think of doing something with sort of a comparative analysis in the same way that Inyaki's, and sorry, that also in Sergi have been doing already with some of you. So that's it from me or from us. Thank you.
Thank you very much. Right now I turned on the microphone. It's much better, I hope. Thank you, Jaren and Barbara, for the presentation with very nice and interesting information. Now, again, place for the questions, remarks, comments from the others. No questions, no remarks. Mark, thank you, Mark. You saved me.
I wanted to raise the hand, so I hit the wrong button. So I think you mentioned it somewhere, but I was very concentrated on this increasing the relative impact of the depths of despair. You got this red line, and so I think that this is a consequence of the fact that you stopped the analysis at the age of 64, right? With the decrease of mortality, the more deaths shift to the ages above 64, and then just the relative impact of those deaths who remain in the younger age groups increases. So this is also why you didn't mention it in the conclusion, because it is this is not just a matter of concern, it is more the absolute trend, like with the suicides, that is more relevant for public health concerns, right?
Yes. I mean, this is the age group where really, I guess over the last also several decades, we've done a lot to cure cancer, or at least be able to make it less lethal, also heart disease. So these middle-aged men are not dying anymore from these traditional men and women from these traditional degenerative diseases, but at a later age. But at the same time, of course, I think that it's definitely worth looking also at these sort of, so to say, causes of death related to lifestyle. So you would expect perhaps that these causes would go with the same trend, even though they're also declining, but it's not the case. So they are, as a proportion, becoming more and more important, and especially I think suicide is I think perhaps a neglected cause in that sense, because as you can see in Spain, unlike perhaps in other countries, alcohol is really declined a lot more than, but still in drugs as well. But that makes a more visible, I guess, other causes such as suicide, which does have a relationship with, of course, alcohol and drug use to some extent. But of course, we analyze that they are mutually exclusive in our analysis. So yes, it's just a way to, I guess, get to the detail within this middle-aged population. So I do think it's important to highlight that perhaps the negative trend of suicide in this aspect.
Any other questions? I have probably one. The Spain is well known for the very rapid change in last, let's say, 20 years in the educational structure. Young generations are much more educated than the older one. How? Because and then in your charts, I have seen many interesting relationships between that causes of death and education. What could we expect if those generations, which will be, and the level of education, higher education is like 40% for younger generation. What we could expect in not in a for the future, but in a few years when the generation became old in the age group which you were focused on.
Good question. I think one of the reasons, especially when we have been looking also at mortality for older age, because older ages, there's always a big. We always spend a lot of time in getting the educational categories right, because the educational situation in Spain started, say, in the 1960s. So for the age group that we looked at, it's going to be less of a problem that we do have a reasonable amount of people in the higher educational categories. I must say though that our higher educated group is not as high as what would be a higher education group in the US. So we've got, for instance, vocational training in university, but it's not like, and our middle categories, our low categories, less than secondary school education. So these people that actually only ended up completing primary school education. So for the youngest ages, that's a problem because all of them now do finish it. But for, say, the 50 plus, there's still quite a few people that actually never actually finished their secondary school education. So we do spend a lot of attention on that, and I think that once there's now this, perhaps a comment also to some of the previous presenters, is that what we think is that part of the reason why the low education, the low education group, say the younger people who's there, they're going to be there that are perhaps of worse health. So reasons why they never got to, say, universities, partly because of perhaps health reasons, but also immigration, I think, is also going to play a more important part as the group that constitutes the low educated population. So yes, and the drinking, for instance, and drugs, well, especially the drinking problems is definitely among the younger generation. It might be more general among all educational groups. And the reason I think, it's pretty much everywhere now. We're getting sort of more towards a sort of Northern European style of drinking as well. So you get all these young adolescents that go out on the weekends and they sit with each other in the park and they drink themselves silly. And this is something that in Spain didn't have 20, 30 years ago. And you do have now. So there is, I wonder what's that going to have in terms of consequences for future health. But because it used to be only for socializing, having something to eat, and you meet up with in a bar or restaurant, or maybe it's the house of the family, so you have a couple of drinks, or maybe 3 or 4 or 5, but always with food. Now more and more you see younger people drinking without food in the middle of the night and so there's a sort of drinking change, pattern change going on, and it will be interesting to see how that's going to translate to health, to morbidity and mortality in the future.
All right, thank you very much. I agree. That's also my opinion. Thank you very much. Any other questions, remarks, comments? If not, thank you again for very nice presentation and answers to our and my question. And we can move to another presentation. Katalin, are you ready?
Hope so.
Hope so. So we have again one presenter from present group.
Yeah, but hybrid form. Yeah.
The hybrid form.
That's the hybrid, yeah. But this doesn't want to give me that.
There.
I cannot find a screen when I can share. It was too much talking.
Okay.
You need some help? Again disconnected. No, it is doing this for forever. So let's just move to. Should I share it for you? Please do. Can share it because that's again join a meeting, so it's.
Okay, we are solving some small technical problems, but give us second, and it will.
Hopefully. Yeah. Why is this? I'm just thinking, seeing the pictures, how some persons are still smiling and not moving at all. And now I notice there are pictures. So very nice.
I was thinking about Mark.
Yeah, Mark was that one that is still smiling.
Smiling man. That's you. Okay. The pyjama.
Now I'm working on sharing. This is where it is located in the on the flash disk, where I can find just the newest one. Is telling life expectancy. This last one? No, this, yeah. COVID. Yes. We can show the COVID certificate. That's also interesting, but probably I can share it for you, or you can use my computer. I think it's the easiest if I sit here, because that's just disconnects. Thank you so much. Sure, I will make it for you. Yeah, thank you. It looks fine. So, okay. Moving. Sorry for this. Then, can you see the? Yeah. Yeah. You have the control. Yeah. I can control it. I'm in person. Yeah. So, basically, I didn't write any introduction, and I think I have done very well, because somehow this issue is connected to everything we were talking about today and even yesterday. So yesterday we had a big debate about how to measure COVID mortality and what would be the good standard to compare with it. And so this was my question, doing some COVID calculation, that what I should, compare for. And that was a very, very big, quick research. What I would like to share you first, that what happened in Europe. And after that, I just realized that many people started to think about this problem. That here and there they discovered that life expectancy is not growing very fast, or not growing at all, or even goes into some negative direction. So first, that was just a quick check what I wanted to do, and why do I have this here? Okay, just sorry. So America, you have heard just in the previous presentation very nicely that America started to talk about causes of despair. For instance, in other countries, especially in the Netherlands and in France, they started to talk about old people who have more mental impairment. And for instance, Alzheimer's disease, which is growing and growing, and probably that is the problem. And we can go later on. I will go through about almost all of the hypotheses, but many people were really interested in. So what I did, that was just for first, that's a quick overview on Eurostat data on life expectancy, which were available for at least 35 years, and that was only 18 European countries. And I did a so-called joint point analysis with the help of this software, which was released by the National Cancer Institute in America. And the important thing is that it can somehow separate trends and locate joint points with some certainties and with some uncertainties. Maybe we can talk about this later, but this very first analysis showed that out of these 18 countries which was in this analysis,
there were no change only in 3 countries. I put Norway as an example for that. There were, let's see, if I'm very generous, there were another 3 where there was a significant slower down of the growth, but there was still growth. But most of the countries, it's a little bit depends on definition. What is the very slow growth, or close to zero growth, or negative growth? That is the majority was these countries. So it seems to be that at least in European context, you can see this, that what we are talking about here, for instance, for Denmark, the last joint point was located in 2016. That is just a 3-year-long period. So it's very uncertain thing whether we can talk about this, whether there is really, really something serious going on or not. But if we go back, you can see the last joint points here. So those is for some countries, it is not an issue. For instance, Lithuania, something absolutely different is going on. Norway, I already showed it, that was also not an issue for Slovakia, because nothing has changed since 1991. But all the other countries, that you can see that the majority of countries have at least an estimated joint point or change of the trend time period around 2014. It's a little bit earlier in Germany, for instance, and there are other countries, for instance, for Belgium, it is located for a little bit later, but it still seems to be that there is a big bunch of countries where there was, including Czech Republic and including Hungary. So we absolutely have this. Where there will be a big, I think that people can debate it whether it is a real different period or not. And of course, with different kinds of assumptions, you can get different results about these joint points and the change of the trends. But also you can realize that at least half of the European countries somehow producing this. There is a little bit more detailed analysis here. For Hungary, for instance, here we have a joint point at about 2013, and the same is for men, basically. It is just so for men and women a little bit, the dynamics, but basically the location is the same. So here we measure the annual percentage change. This is the EPC4. It means that earlier, this EPC means that in every second year there was an additional year gain, additional more year in life expectancy, and this goes back to that situation when you have to wait for 8 or even more years to have one additional year. It's almost no growth, and this situation is even worse for women. That is absolutely 9 years, while we have another additional. So that's a big difference. So. As I mentioned, other people also were thinking about this. So in some countries, this new emerging diseases like Alzheimer was in focus. In other countries, the despairs of life causes of death, which were just analyzed very nicely in the previous one. Also, Americans preferred to calculate. Because they had, other Americans had image that it is all about obesity, and because of very fat people, they will live less and less, and now it is already reached that that limit, that it is seriously impairing Americans. So obesity, and also there were other and very not easily checkable hypotheses like influenza pandemics. So others were just say that influenza is more powerful and less controlled in Europe and more frequent also. So, and if you look at these little, oscillation, they more or less coincides with the big influenza pandemics. It's, of course, you can say that is also. Also, I didn't want to put any names because among the audience there are people who were writing about this. So there are also those kinds of examinations. For instance, about the smoking, we have heard about this today also. That earlier about the Danish woman, there were a number of studies have been published that a certain cohort and a certain lifestyle change somehow causes something long last has some far-reaching results in regarding life expectancy. The most powerful thing, however, is that the diminishing improvement of cardiovascular mortality, because cardiovascular mortality was the engine of life expectancy growth in the last decades. So in this European setting, that would be probably the most important thing to examine. So, and behind this there is another question, whether how it is doing with the social disparities. So, for instance, if we look at cardiovascular diseases, that again a big question, that whether there is stop in that at least relative narrowing, which we have seen in cardiovascular mortalities between the different social groups, if there was any, then a big question. So many hypotheses, and I will answer, of course, none of them, but I will try to just give something. It's a little decomposition what I wanted to show you. So we have taken, with my dear colleague Lajos, we have taken two periods, 7-year-long periods, and we try to pick up those diseases which are important. So there are a couple of cancers which are absolutely preventable or avoidable. Colorectal cancer, for instance, that is known to be held. We do know that we have a problem with on the prevention side. Breast cancer is also very preventable, and lung cancer is already discussed pretty much in details in this meeting. So other cancers, we looked at cardiovascular diseases in different groups because of their treatment. So cerebrovascular diseases and ischemic heart diseases are treated by different medical networks. So I just wanted to see whether there is any difference between these, and also there is a big group of other cardiovascular diseases. We have taken diabetes just to check whether this fatness thing has already reached the level of mortality. And we also constructed a DAP group, but that's a little bit of, so we've put together dementia, Alzheimer's disease, and Parkinson's disease, because these were the ones which were the Hungarians really used as cause of death. There are many others but I think this is very, very icy when we would like to do some international comparison, because people usually have different coding methods for this. So some countries I'm sure over code Alzheimer's disease, others over code Parkinson's disease. We have chronic liver disease just to illustrate the problem of alcohol. And we have suicide and other external causes. We didn't create it a very sophisticated despair of life stuff, because suicide was always a very important issue in Hungary. And as we will see, other external causes as well. So as the results, very, very similar patterns are emerging for men and women. It's a bit bigger for men. The gain which has been characteristic for the period between 2007 and 13, than compared to the next 7-year-long period. As you can see, that the gain is smaller and smaller, almost halved. So basically, this is why, because this is in this way we put together men and women for a short period. But we can see that the big gain, which was here in this younger middle age group, that it has been reduced very much. And for those in the older middle age group, I would say that has disappeared. So no more gain anymore for these 50s, 60s, early 70s group. There is no more. Interestingly, which I would like to mention, that there is still gain and not much among the oldest age group. So this makes it a very little bit unlikely that it was influenza, because influenza also targeted the oldest age group. So if you look at it more in detail, what happened, again, it's a little bit even more dramatic to me, that everything which was connected to younger age group disappeared, and after then there is still some gain around 40 and 50, but much less than it was previously. And now we can go toward the cause of death results. So lung cancer was a little bit beneficial. In the earlier period, it produced a little bit 0.04 years, so very little, a little bit more in the next period. Breast cancer is, of course, very little. Other cancers are doing pretty much in the same way. But you can say that the diabetes is very small cause of death. In fact, if you look at the whole picture, diabetes was good in the first period, but it had nothing. So probably there is something about this fatness stuff, but this is not the main reason, because we don't have life expectancy improvement anymore. Its contribution is very small, and that is also true for the mental disease categories. So Alzheimer and Parkinson and dementia altogether counted very little in Hungary. It has no role, basically, in shaping life expectancy gain or change at all. Which does matter, that is what you can see, that ischemic heart disease, its contribution has halved. The same for cerebrovascular disease, that remained almost the same, but other circulatory disease, the contribution has went into the negative side, so that has disappeared, we can see. The suicide is not really changing, or even if it is more, if it is more positive in the second part of the, in the second period examined, which is very important. Those are the so-called other external causes. Other external causes, those are falls and traffic accidents mainly. And very quick inner look into this data set that not just the traffic accidents. So the interpretation is that in the first period around let's say 2010, in this period we became a little bit more civilized. We just didn't speed so much. We started to follow the rules, but the detailed look says that also these falls are important. It's accidental falls is the name for those mostly old people. Mostly old people die because of these falls. So it says something about me, about caring old people. So somehow this part is not really improved in this during this period. So the most important thing is chronic liver disease, which is the most shocking and which I would like to finish it with. So there was chronic liver disease. This is not the alcohol-related mortality. It is just a kind of, symbolic, I would say symbolic stuff, because it is much smaller than the actual alcohol attributable mortality or whatever. So what you can see here, that was almost 1/3 year, which was positive in the first period, and that has disappeared. So there is no more improvement in the alcohol side anymore, which is a little bit tragic news, and it tells me that somehow this regime goes back, this mortality regime goes back toward those things we were talking about 20 years ago. So somehow no improvement in the field of heart disease and cardiovascular disease, and no improvement in the field of alcohol. Thank you very much for your attention.
Yeah, thank you very much for nice presentation. And
oh, sorry, just these ones. Just look.
Okay.
Look at this, so colorful.
Yeah. At the first moment, I thought it's a flag of some state, but okay.
No.
Okay.
One more glass and
this.
So just a couple of us. The blue area is about different cardiovascular. So detailed age group and the contribution of cardiovascular diseases. That is the blue, and this yellowish, that is the chronic liver disease. That's the contribution of the different causes in the first period, and what you can see that the yellowish is absolutely disappeared, and the blue area is very, very small. So it's somehow this black one is the cancer that is still in the same amount than it was before. And I think this is quite dramatic if you really would like to see very, very colorful, I think this one is nicer. So yeah, but anyway, that no one can read this. The important message was in the previous graph. So basically this is what we could see for the moment.
Okay, thank you very much again. And right now, time for questions, remarks, comments. No, I don't see any hand.
Sharing.
Yeah. Take it
John,
back.
you can ask.
Your computer.
It's no problem.
Yeah.
Jon?
Yeah.
Thank you. Thank you for that very good technical analysis. I'm wondering if there is less here than meets the eye. The folks in the Rostock, Jimbo Bell and others, convinced us that life expectancy has to go up in a straight line. Jacques in France said maybe not. And what you're showing us is that life expectancy is basically going up. It's not going up in a straight line. And yes, there are small, very, very slight changes in certain minor diseases. I'm not sure this is something to get worried about. There's the real pattern of change in mortality rates by age is a sort of cohort effect that's really halting mortality decline. Is there any sign that there's a real age group which is under threat, which is going to bring us mortality increase? Or are we seeing just some kind of catching up with different things happen at different ages, different diseases shift in their importance? I'm saying, is there really a crisis, or is it just a scream because it isn't going up in a straight line anymore?
Well, I really don't understand the question. So you mean that you won't realize that your relatives will die earlier than in Israel or nothing? So that's given this very low, if you take this very low life expectancy, which for instance Hungary has, of course you would like to see the improvement. And there was nothing, you could hope for very long that there will be some improvement. And also it is still true for the Czech Republic, I believe, that you need a little bit of improvement, or you believe in improvement, yeah? And if you go back for what Patrick said, that he said that what is the meaning of this? Progress. Yeah, this is what people think and what people associate with life expectancy improvement. They think that, okay, that's progress, improvement, generally speaking.
I'm just saying, in your initial things, you showed that life expectancy is basically going up. It's not going up in a straight line, you've got breakpoints. Life expectancy isn't necessarily going up in a straight line anymore. I can think of all sorts of reasons why that might happen, including the fact that life expectancy is limited. It's not going to go up in a straight line indefinitely. It has to level off at some point. Various countries have all sorts of things in their history. Hungary, in particular, not only Hungary, other Eastern European countries, which are probably still showing effects of the, shall we call it, the so-called socialist trauma. There are all sorts of things going on. But to say that there is a catastrophe, to say that there is a real crisis, I think that's exaggerated.
Who said that it was a catastrophe? I said that it was a change.
It sounded like the way you presented it at the beginning, that there's a serious problem. I'm not sure there's a serious problem, that's all.
Isn't it? Well, the problem is that, yeah, I think that we have already this discussion whether this time, which is in most countries, you can see between this trend change and the COVID, that is 4 or 5 years. It's not a tragedy, it's just an important thing because that's demography, they studied life expectancy, and if it is not going up anywhere, then that seems to be a serious change. And of course, it is a big question. And I think it is really important to discuss whether there is anything to believe in this, because just forgetting about it, it's impossible. The practical thing was just was when I looked at these calculations, and there were many people who did automatically these, averages of the previous 5 years, and sometimes it is okay. Unfortunately, because there is no change, then this is okay. But for some countries, it was not okay. For instance, for Sweden, it has to be, a kind of projection had to be done in order to have some good COVID measures, COVID numbers. But for the other countries, it was okay. So